Welcome, everybody, to another episode of We Care Health Talks. I am your host, Udit, and I'm joined once again with our main host, our main guest and speaker, Dr. Sant.
Hi, Udit.
Thank you very much for being here once again.
You're welcome.
Today's topic will be cholesterol and blood lipids. Something you will be very familiar with, I am sure, in your field of practice, being a cardiovascular surgeon. Is that correct?
Yes.
Yes. So let's start with the very basics. As always, for everyone, what is cholesterol and what are blood lipids?
Cholesterol is a substance, say, a waxy substance inside our cells, nearly every cells of the body. It is used in making cell membrane, in building hormones, including in building vitamin D from the sunlight. So cholesterol is an important or essential thing that we cannot live without it. The lipid, or more precisely, lipoprotein, is a molecule that wrap cholesterol. Suppose this is cholesterol, a bulk of cholesterol. Lipoprotein is the lipid and protein that wrap it up. So that the whole thing we call lipoprotein. The idea is that the body can transport this complex. Outside is lipoprotein, inside is cholesterol, can transport it in the bloodstream, because cholesterol itself, it is waxy stuff. It cannot be transported through the water. The blood is the water. It needs lipoprotein. So the lipoprotein is a complex molecule, consists of cholesterol inside and lipid plus protein outside. That's the definition.
That's the definition of what is cholesterol. So cholesterol is found in all of our cells in the body? No.
Nearly all.
Okay. In the cell membrane.
Yeah. Human cell, usually, if not a specialized cell, usually all human cells consist of cell membrane to keep the fluid inside, what we call cytoplasm inside. So it is essential for our life.
Okay. And then obviously anyone who has done a blood checkup would have heard of these terms, LDL and HDL.
LDL and HDL are names for lipoprotein. There are many names. LDL, low density lipoprotein, and HDL, high density lipoprotein, are two names that most familiar to us, because we use this. Actually, we use LDL mainly as the indicator or as the risk factors of the cardiovascular disease. That's why we are very familiar with LDL a little bit more than HDL.
Right. So what is the main differences between the two molecules? Or is this just the naming that we give to them?
No. Chemically, the density. The density is the weight of the molecule. LDL is low density lipoprotein. It's lighter. HDL is high density lipoprotein. But the significance of it is that the LDL level in our bloodstream relate to incidence of cardiovascular disease. Somehow they relate to each other. The HDL relate to inversely to the incidence of cardiovascular disease. The higher the HDL, the less chance to get cardiovascular disease. So the significance is its meaning. Mhm.
But there are also other types of cholesterol as well. I have seen sometimes VDL, is that very low, VL, or what are the other types of cholesterol?
Oh,
That
there are many actually.
Okay.
VLDL is very low density lipoprotein.
Yes.
Actually, there are many type of lipoprotein identified in the body, but the clinically significant only the LDL and LDL and HDL.
Okay. So for now, let's ignore the other types of cholesterol just to stay focused on this part.
Right.
So first, why is high cholesterol a risk factor for cardiovascular diseases?
Precisely why LDL?
Why is LDL
related to
yes
cardiovascular disease? Actually, the answer is we don't know. Actually, we don't know even is LDL really related to cardiovascular disease. We know it roughly related, but it is not the cause of cardiovascular disease. We cannot prove the causality, the cause and the effect of these two things, I mean the cardiovascular disease and LDL. We cannot prove that high LDL cause cardiovascular disease. No, we can't. But we can say that these two things have a linear relation. When LDL is higher, the incidence of disease is higher. Something like that. That's all we know. So we cannot answer is the LDL the cause of the cardiovascular disease. Why it is the cause? We don't know. Actually, we don't know the real cause of cardiovascular disease.
All we can say is that high LDL, high cases of cardiovascular diseases.
Right.
There's a direct correlation is a linear correlation in the two of them.
Right.
But we don't know whether it is a causation effect.
No. And some new evidence kind of contrast or contradict to our own old belief that the higher the LDL, the higher the incidence of the disease. Because in some study, in some circumstance, there is kind of not significant relation between these two things. So at the moment, medical community in the mainstream still recognize the correlation between LDL and cardiovascular disease. But in the future, no one knows. It may be changed because new evidence, more evidence coming up, and that sway our belief a little bit. But at the moment, the mainstream still recognize LDL.
Fair enough. So let's talk about the numbers. What is the recommended numbers for your cholesterol for people who might be interested?
Nowadays, we focus only in LDL. We do not use the term total cholesterol because it's kind of confusing for people.
It includes triglycerides. Is that correct?
We said total cholesterol. In mathematics, it equals to LDL plus HDL plus 1/5 of triglycerides. So sometimes HDL is high, so they check up the value of total cholesterol. So nowadays we use only LDL mainly to address the risk of the disease. And what is your question? I forgot. So
what are the numbers? What's the number for LDL? What's the recommended? What do you suggest for someone?
Well, that is
a healthy number.
Well, agreement. What we call guidelines in medical community. Then we stratify patients or general people into three categories based on the likelihood or the risk of having disease. The highest risk people classify as those who already got the disease, defined by already be admitted to hospital and treated by their symptom, like already have stroke or already have acute myocardial infarction, something like that. That category is the highest risk group. We recommend the LDL should be lower than 70, 70 milligram per deciliter. And this again is the controversial number. For the hardcore cardiologists, particularly in Europe, they would prefer number 55.
Wow.
But for those people who care more about the brain, particularly neurologists, they prefer number not less than 100. So I would say 70. It's probably
a safe middle ground.
Yeah, middle ground for those high risk people.
Okay.
The second group is those moderate risk people, defined by the people with, apart from the high cholesterol, they have another one major risk, at least, such as they have hypertension, or they have they smoke. That is another one risk. So this we categorize as medium risk people. This group we recommend LDL should not more than 130 milligram per deciliter. For the rest, we classify them as the low risk, no identifiable major risk apart from cholesterol. We recommend there are two numbers because medical community themselves, they cannot make agreement. So they end up to recommended number. The lower side is not more than 160. Those who prefer the higher side, me in this group, not more than 190.
For LDL only.
For LDL only, we talking about LDL only.
Yes. Okay. 160 to 190.
Yeah.
Sure.
So you see, there are three categories based on the risk of the patient. We do not use just one number for all. That's the wrong way to
Got it.
to approach the LDL level in relation to in view of management of the LDL.
But isn't the general trend as you get older, most people their cholesterol gets worse?
That is not true. There are many good studies in community, particularly in original community, like one study done in Bolivia in Amazon jungle. The cholesterol level kind of stay flat right from birth to 90 years, 100 years old.
Okay.
And when I say stay flat, the LDL is on the very low side. Those people, 50, something around that. There is another good study done in China, a very famous one called the China study. Yeah. Led by T. Colin Campbell. In rural area of China, their average LDL is about 50.
Wow.
50. And that since birth to what very old age, 90 or even 100. So it's not true that LDL will keep coming when we get older. That's not true. It's our food.
It's just we keep eating the same. Our lifestyle choices obviously continue to get worse over time. Not worse, but accumulation of many years of the same habits.
Yeah, I think it's mainly the surplus of the calorie intake.
Right. So body weight goes up as well.
Yeah, because people tend to think that they used to eat this amount yesterday. So today they should eat the same amount.
They need to eat less.
Yeah, actually they need to eat less because the older they get, the less energy they spend.
Right. You spend less energy with age. That's actually
Right.
pretty interesting. You said 50, 70, that those numbers. Let's talk. Is that possible without taking statins, or like can you talk a little bit about statins?
We have two issues here. Let's talk about the
medication.
No, the food factor first.
Okay.
Because the first step in management of hypercholesterol, high cholesterol, we will not talk about the medication.
Okay.
We will talk about the food, food selection, food change. The question is it possible to eat food and keep your LDL as low as 50?
Yes.
Of course, it's possible. It's come from research in many original community, what I mentioned. And there is one research done in Spain not long ago. They studied the level of LDL in three groups of four groups of population. The omnivore, those who eat meat and plants, and the ovo-vegetarian, those vegetarian who eat
eggs
also, and the lacto-vegetarian, those vegetarian who eat milk
and egg,
and lacto only
milk, no egg,
and vegan.
Yes.
Four group of people, very big size of people, large amount of numbers. It turned out the ovo-vegetarian, they have average LDL 123 milligram per DL. The ovo-vegetarian, they had 101 milligram per DL of LDL. The lacto-vegetarian, they had something like 89 milligram per DL. The vegan, they had 69. So you see, this is based on food only. Nowadays, not in the primitive community. In a normal community nowadays, food pattern only can differentiate very large variety of LDL level. So it is possible to change food alone and keep your LDL at desirable level, which is possible. This is not possible. It is not impossible.
Of course.
Possible.
It's possible through your food choices. But for those people where the doctor has put them on medication, can you explain a little bit how the mechanics of it works?
We don't know how the statin, the medication we use nowadays, about 90% or probably 95% are statins. We don't know for sure how statin works. We don't know for sure. It could be statin is anti-inflammatory drug. But for sure, statin reduce LDL. But we don't know whether reducing LDL is related to reducing incidence of disease or not.
Okay.
It may be other function of statin. We don't know. So when you ask how statin reduce incidence of disease, we don't know. Medical community, we don't know. We know is that when people who have high risk, we give them statin and the risk coming down. The incidence of ending up with the major adverse outcome of the disease is coming down. We don't know the mechanism. But the main point is that in management of high cholesterol, statin or drug is not cornerstone of management. It's the food.
Number one is the food choices.
Number one is the food. And we got to do this first. And we got to give time to focus on this in changing food. Unfortunately, changing food is difficult because food practically is addictive to our brain. The similar way we are addicted to heroin, morphine, or whatever. The mechanism is exactly the same. So that is why changing food is difficult. And that is why behavior medicine is important. And that is why maybe in the near future, coaching is the main method to do this sort of lifestyle modification. Because addiction is the main problem.
Right. And the main things to avoid if you are looking to lower your cholesterol is saturated fat.
Yeah. Saturated fat. But we do not have enough data to say. We know from some research that some source of saturated fat doesn't increase the incidence of disease. For instance, if you eat yogurt, full cream yogurt,
Full fat
full
yogurt.
fat yogurt, but the incidence of disease is not coming up.
Right.
But if you eat animal meat, the incidence of disease coming up at the same LDL. Another one good study, the Lyon Heart study. And you have heard about Mediterranean diet.
Yes.
The Lyon Heart study is the study that popularized the Mediterranean diet. In this study, they bring 400 something people, divide them into two groups. This group, they just give them to follow simply put it, the American diet. Another group to follow the Mediterranean diet. Incidentally, at the end of the study, by the time they stop study, the number of total cholesterol in those days, they use total cholesterol. The number of total cholesterol are exactly the same, 229 milligram per DL in both groups. So both groups are high fat diet, equally high fat diet. And nowadays we equate the total cholesterol at the same meaning as LDL. So it's practical to say that both groups have the same LDL. But the incidence of disease is much different, much lower in Mediterranean group and much higher in control group. Because in Mediterranean group, they acquire the calorie mostly from plant. But the control group, their calorie mostly come from animal products. So the source of LDL is one thing that we don't know for sure in detail. Not just LDL can check you up the incidence of the disease.
Right.
Where LDL come from is another important thing.
They were also eating more fiber, maybe, in the Mediterranean diet.
Oh yes,
who knows? But you're saying that the LDL was the same.
Yeah, we know that what is the difference between control diet and Mediterranean diet. Number one is source of calorie, mainly plant in this Mediterranean diet. The content of fiber is higher in Mediterranean diet.
Yeah.
The other thing that it is not mentioned in the report is that the Mediterranean diet, people who eat Mediterranean diet, their culture, they come with, this diet occur. It's found out in what we call Greek island in Greece. Greek. And there are population of Greek Orthodox religion. And in that religion believe they do fasting. 199 days in a year. So fasting is another component of Mediterranean diet.
Oh,
That is one thing. Red wine, of course, is the other component because they always, I mean, when I said always, I mean in not breakfast but lunch and dinner.
they have a glass
Every
of wine.
lunch and dinner they have red wine. Olive oil is another
Big
character
part
of
of
the
their diet.
Mediterranean diet. Nut and bean, also another part. So this component is a different part from the control diet. Altogether make up Mediterranean diet, which contribute to better outcome of the disease.
Okay. I have to ask, eggs, high in cholesterol, almost 340 or etc. milligrams per 100 grams, high in saturated fat, high in protein, high in vitamins and minerals. Is it a health food? Is it a superfood? What is your opinion on eggs?
Before going to my opinion,
What is the
by definition of the USDA, I mean the US government, egg is not a health food.
Egg is not a health food? Is that your opinion or the
No, the USDA.
USDA?
The egg board, I mean people who earn their living by selling egg board. they try to make egg healthy food, but it's not successful because scientific evidence is not direct that way. I will give you the picture of some study. The biggest study done by Harvard, we call the Women Health Trial. They follow the nurses, 80,000 nurses, follow them for 13 years, very long time. Divided into two groups. Group one is the egg lover nurses.
Yeah.
They find that they eat more than 7 eggs a week. The non-lover defined as they eat egg less than 7 eggs
a
week. Follow them for 13 years. The endpoint is the mortality rate, the incidence of cardiovascular disease and other chronic disease, including cancer. All exactly the same. So egg do not make difference. Egg or not egg, more or less do not make difference in general people's health. But there is one small group of population in this study, about 5%. If they eat egg, the health outcome will be worse. This group, they tend to be a diabetic, diabetes tendency, and they have higher blood cholesterol. In those days, they use cholesterol. So I would say egg is okay for general people. But if you have higher LDL or if you are diabetic, I think egg probably not very friendly for you.
Right. So those were the hyper responders to egg.
Right.
About 5% of people may have some health risks associated with eating more than 1 egg a day.
The easiest way to make diagnosis whether you are egg is good for you or not is your LDL.
Check your LDL.
If your LDL is high, I think probably less egg is better.
Right. That's very interesting. What about, so all of the cholesterol is in the egg yolk, right? What if I eat only the egg white?
The egg white is okay.
It's all protein.
That is albumin. There is no cholesterol in there. Actually, we don't know for sure at the moment whether cholesterol in the diet relate to
cholesterol in the blood,
the level of LDL in our bloodstream. The relation is there, about 6% of population, I think. So I think the best thing to do, egg or not egg, is not important as your LDL.
Right.
If your LDL is on the high side, you got to change your diet.
Mm.
The way to change it will be based on the study done in Spain. You go more toward plant-based diet. It is kind of spectrum, you know. One end is you eat mostly
Carnivore.
Yeah.
Right now, there's a big
The other
carnivore
end is
group.
vegan.
The other end is vegan.
There's a spectrum. You can choose what suits you. The more you go toward the vegan, and the less your LDL. That is the basic principle of food management for those who have higher LDL level.
Right. There has to be something in the middle, which everyone can find. Outside of food, anything else you recommend to your patients for reducing their risk of high cholesterol?
To reducing risk of cardiovascular disease
Or just
and chronic
disease in general?
Because we care about LDL, because it relates to many chronic diseases.
Yeah.
Actually, before I answer this question, actually when the angina pectoris, the name of the ischemic heart disease, come out, it is first mentioned in relation to stress.
Stress.
And this is appear in the textbook. In the medical community, we recognize a doctor named Sir William Osler. He was a Canadian, something very long ago, 1892, something like that. And he wrote a textbook of medicine. And the first mention about angina pectoris, the assumption of the cause is the stress, not food. Not food. So there are many contributors to the angina pectoris, to ischemic heart disease. Stress is, of course, a major player, probably bigger than food. Probably bigger than food.
Because it increases your blood pressure, or many factors?
In many ways, yeah, in many ways. Study in monkey, stress can create inflammation by itself.
Oh, wow.
Nothing else, just stress. So there are many factors. So it got to be, to minimize the risk of the cardiovascular disease, it got to be a combo of things, combination of things. You got to manage your stress. You got to change your food. The LDL is a very good guide. And better still is your body mass index.
BMI.
Your body weight, yeah.
Or your...
Very good guide. Because usually go together. When you are obese, your LDL will be high. Manage your stress. Manage your food toward plant-based food. And do exercise. Exercise alone can reduce the mortality of chronic disease through many mechanisms. So exercise is another one important component. And the latest research done by Harvard, good relation with people around you also bring down the incidence of major adverse outcome of the disease. So at least these four things.
Yeah.
Your food, you're managing your stress, exercise, and having good relation with people around you. These four components are important to reduce your chronic disease, particularly cardiovascular disease.
I think for almost all diseases, basically, if you are at an ideal weight, the risk factor will come down. Is that a fair statement to say that the number one thing people can do is make sure that they are in a healthy body weight with a low fat percentage?
Yes, it's fair enough to say that, because hereditary factors. Now, since we know a lot about the genome mapping and effect of gene, now we generally accept that hereditary factor influence only about 3.7% of chronic disease. I mean, we cannot change it. In this 3.7%, you are destined to end up with this chronic disease. But the 3.7% is very low number. So it's fair to say that your lifestyle, what you mentioned, is if you change toward a healthy lifestyle, that is the best way to prevent and reverse your chronic diseases, including cancer, and particularly including dementia. Dementia is also the lifestyle disease.
All of these can be attributed to some sort of
Yes,
lifestyle.
because nowadays we have a lot more research about Alzheimer and dementia. It turns out that the major players are cardiovascular risk factors. If you manage these factors well, you're better off in terms of dementia and Alzheimer's disease. Genetic is only not more than 5%.
So genetics is low, but so me and my partner, maybe we eat similar food, similar lifestyle, but our cholesterol level may be very different.
Yes,
That's possible.
that's possible. But
She has better genetics.
to start with, but the disease outcome is influenced by environmental factors, much more than genetics.
For sure, of course. Yeah. Like this is just an example. If I'm your patient, I have like 240 LDL, but my HDL is like 120, 150, and I'm normal body weight. Do you think the patient is at risk if they are healthy and fit, but they have, let's say, 200 plus LDL?
There is no research to answer this. We recognize HDL from the very old research called Framingham Heart Study. That's very old. And later on, we nearly neglect HDL. So we don't know much about influence of HDL in terms of the risk of diseases. So if people have higher HDL, we accept generally from the Framingham Heart Study that they have better chance to tolerate the disease. But if people have very high HDL, say 100 plus HDL, we don't know. But we know that the relation between LDL and disease is for sure. And we know that if we somehow manage to reduce LDL, usually the risk of disease will be reduced. That's we know for sure. So managing LDL is still the mainstream of medical practice.
Okay. So 200, you would still want to bring it down. And nowadays, people are also testing LDL A, B, C. These, can you explain what these are?
The attempt to assess risk is a part of making diagnosis, because we cannot make diagnosis from what we call pathology study. So we got to make diagnosis based on risk. So people try to identify risk. People try to looking for new risk factors.
More information.
Yeah. Lipoprotein
A, B, C, D.
For instance. But all of that are useless. Because, the risk profile of general population, like in Thailand, say in Thailand. There are two studies that worth mentioning in Thailand. One is study the whole country, 10-something thousand people sampling from all parts of the countries to see the level of their cholesterol. But 68% are hypercholesterolemia of adult population in Thailand. So this high percentage, there's no point trying to identify your risk factors. You chance that you have 2/3 chance to get the disease. The point is to start manage the risk.
Reduce the LDL.
Yeah, start manage the risk. No point trying to make a more correct diagnosis. No point. The other study done among the doctors and nurses in Srinakarin Hospital in Khon Kaen province. They check LDL level of doctors and nurses. 67% of them have high
cholesterol.
High cholesterol. 67%.
So the same as the general population.
About the same.
2 in 3.
Yeah. So at this level of risk, there's no point trying to seek for another risk factors. There's no point. Just sit down and manage the risk. That's
you already have high cholesterol over 130, 150. Just get that down first.
Yeah. Once in the lifetime, it's worth checking your blood cholesterol.
Yeah.
If it's low, and if you don't change food, okay, 4 or 5 years, you check it again. But if it's high, I would recommend you check the level every year.
Yeah.
Meanwhile, you manage your food, okay, change food. Try to bring it down through lifestyle modification and check it once a year.
I do blood test once a year, as you say. I think just the very last part of the blood lipids is the triglycerides. Can you explain very quickly about that as well?
Well, in the old day, we thought triglycerides independent risk factor of the cardiovascular disease. But now we know that if we separate high LDL out, in the triglyceride that coming up independent from LDL is relatively meaningless in terms of cardiovascular disease. But it says something about the risk of another disease, what we call pancreatitis, acute pancreatitis. And the risk for that disease will be significantly high if the triglyceride level exceeds 1,000 milligram per deciliter. And in medical community, we agree that if the triglyceride higher than 500 milligram per deciliter, we will do something. Do something, I mean, I got to change food or whatever. So if it's lower than 500, there's no point be bothered with it.
Not too bothered. Okay. So my key takeaways from what you have said would be check your blood once a year, blood lipids, check for LDL, more important than HDL. The total number is not so important. Same for triglycerides. If you have other risk factors, for example, high blood pressure, high sugar, or maybe some other incidents of chronic diseases, then you want to make sure that number is lower than 130.
Right.
Then if your number is high, make sure that you test yourself every year. Fix your lifestyle changes, starting with food, exercise, stress management.
Right.
If the number is not going down, you need to maybe you're not changing your lifestyle enough.
I mentioned giving time.
Give it time, a few years.
Giving time to yourself to manage lifestyle.
Right.
In ordinary guideline, we will recommend 6 weeks for change, but that is not enough.
It's not
enough. Not enough. I will give time. So, based on yearly basis, I will give enough time so that people can change. And during that time, we focus on coaching, try to bring out the intrinsic motivation so that they can change their habit. But even though when you give fully enough time and still the LDL is high, I think that is the indication to use the statin.
If you really need to, after many years of trying through diet and exercise, and obviously if your body weight is now normal, you've lost weight, many other factors, but that is probably a very rare case.
Very rare. I never see any.
Doesn't really.
In my practice, if they are successful in changing habit, the LDL always
will come down. I think. Do you mind sharing your number?
You know,
your LDL is.
When I was 55, now I'm 62 now.
Okay.
That was 72.
72.
Yeah. When I was 55, at the time I had a ischemic heart disease. I had a chest pain, and in those days they used total cholesterol. My total cholesterol is 268. Nowadays we recognize 200 as the cut point. 268 total cholesterol.
LDL.
In those days we did not measure.
They didn't separate it.
I would assume LDL would be around 200.
Yeah.
And in those days I used statin. I use anti-hypertensive drug because my systolic blood pressure is 167, something like that. I use statin. I use anti-hypertensive drug. I use antidepressant.
Oh, wow.
To calm down my nerve because
anxious.
Because my colleague who treat me, the method of bring down blood pressure is to calm down the nerve also.
Okay.
Yeah, I heed the instruction and took all those stuff, and it went nowhere, you know.
Yeah.
But when I start manage my lifestyle, change my lifestyle, in 6 months, and I quit all medications, and my total cholesterol coming down to 200. I was very happy at that time. Still, I eat 1 egg a day in India, in lunch, at lunch, for about 5 years. 1 egg in salad every day. That I was fed up with the eggs.
Egg lover.
So I stopped eating egg. And since then, my total cholesterol come down to 150, and my LDL is around 70.
Wow, that is amazing.
Without medication, and I am not 100% vegan. You know?
Yeah,
I would call myself a flexitarian nowadays because when I go to talk here and there, people give me things to eat.
Of course.
I cannot refuse. I got to eat, but I just take the animal out, try to eat the plant. But when I'm at home, I'm vegan. So about the patient, I never see anyone who can change their food habit and cannot manage the cholesterol. Never seen anyone.
Yeah. If you follow the plans, the results will come there. I am doing I haven't done my blood check this year, so maybe the next time we meet, I will come and share my LDL numbers for this year, but they're definitely not below 100 like you. So I think it's quite impressive what you do.
But don't forget the point that good health is a combination of things.
Many factors.
Don't over focus on one factor. And that is what we call the reductionism way to do things. It's not way to do thing about health, you know, because health is a combination of things. So you got to change 6 components of lifestyle when
Yes.
we mentioned last time. Food, exercise, stress management, better relation with people around you, sleep, and toxic substance from outside. You've got to manage all of them.
This is only one number, of course. You shouldn't be so
Right.
fixated on it.
Right.
Any final points before we wrap up you want to share along the topic of blood cholesterols and blood lipids from your side? I think you've been very clear and very fair about the science that a lot of things are still, we just don't know. But obviously, if you want to be cautious, it's no harm. There's no negative side effects to having a low blood cholesterol.
Oh, yes. There is no negative effect. Because in the study of primitive community that they are in good health, their LDL, like I mentioned, around 50, very, very low. That's normal. So, but you can see, not long ago we have a doctor with us, young as you, Dr. Net.
Yep.
When he started working here, his LDL is around 130, which is normal of his age. But 2 years passed by, his LDL come down to 50, something like that. Because he got free lunch here, free diet here, vegan diet. So what I would emphasize again is that do not pay attention. Try to diagnose the disease of yourself, but pay attention to change your lifestyle. That is the point.
Yeah, that's what living at the Wellness Center can do for you. I had a really enjoyable time today talking with you. I've also learned a lot of things, and I hope everyone watching also got to learn a few things. Thank you very much, Dr. Sant, for your time. And we'll see you guys in the next episode of the Wellness We Care Health Talks. Thank you very much.
Thank you. Goodbye.
Bye.